Thank you.
I'm Veera.
Nice to meet you.
And we have Professor Giridhar with us, who is a senior neonatologist and professor of neonatology from India.
Welcome, Dr. Trent Tipple. Nice to meet you. Very nice to meet you.
You as well.
So we are eager to listen to Dr. Frederico, and I think he works under you.
Yes, yeah, he's a member, a very valuable member of our section.
I see. So I think it's going to be a very good experience for us, also knowing from experts who have done a lot of work in this field. So when do we start?
We can wait for a bit more time. I mean, I think it's only 8:59 now.
Yeah.
Professor Tipple, I was introduced to Frederico by Edgardo Sild. Incidentally, myself, Dr. Sild and Charles Rower, we had a collaboration together on the meconium paper.
Okay.
And I was introduced to Professor Gary Weiner as well from US. These are the only two connections I have.
So he was Dr. Weiner was an attending when I was in medical school. And so I still remember actually having him give a ventilator talk when I was a third-year medical student.
Oh, great!
Many years ago.
So we are doing lots of papers together with Weiner because he's very systematic with his approach in evaluating the manuscripts.
Absolutely.
And he's like an English teacher actually.
Yeah, he's fantastic.
And nice to talk to you and Frederico as well.
Well, thank you so much. You as well. So you're in Oslo now?
No, I went to Oslo for 3 months and I did my fellowship in UK for a year. Now I'm back in India due to pandemic related reasons. I had to come back.
I was at University of Alabama, Birmingham, and we would have fellows coming from Oslo to our NICU. And so I don't know if ultimately you ever crossed paths with Catherine Overa.
Ola used to be there. Ola Sogstad.
Ola Sogstad, yeah. And but yeah, it was a lot of fun to meet.
Yes.
To meet neonatology trainees who would come for a year to work in Alabama.
Yes.
As part of their fellowship.
The happiest people in the world.
Yes.
So we had a collaboration with Oslo University. So 2 doctors used to go there along with a couple of nurses, and their doctors and nurses used to come to our center. Because they had less manpower, their doctors did not come, but their nurses were actively involved in the care of babies in India.
Oh, wow.
So very similar to what the trainees were doing with your university.
Yeah.
Shall we start, Giridhar sir?
Yeah, please. I think we have 20 attendees now. Can we start? So
they will join us now. Good evening, everyone, and good morning to all from the States. Today we have a very interesting talk on use of inhaled nitric oxide in preterm newborns of less than 34 weeks gestational age. So the use of inhaled nitric oxide in late preterm and term newborns is not controversial, and there is strong recommendation with a high level of evidence or certainty of evidence to suggest benefits. But when it comes to less than 34 weeks gestation, academic bodies such as AAP advise against routine or rescue use of inhaled nitric oxide. Despite such recommendations of grade 1A strength as per AHA classification, we clinicians continue to use it off-label. So what we are interested in today's talk is to see that particular subgroup of newborns who might benefit from the use of nitric oxide and the possible adverse events if you routinely use it. To give us the lecture to the talk is Dr. Frederico Vieira from the States. He completed his undergraduation from Brazil and moved to US, where he did his pediatric residency and neonatal perinatal fellowship. He has been very active in research activities in recent years. His areas of interest include retinopathy of prematurity and neonatal hemodynamics. He is presently the principal investigator for the NIH-sponsored SILO2 study, which evaluates the potential role of sildenafil in preventing bronchopulmonary dysplasia in high-risk preterm newborns. Sildenafil is something that we routinely use in India as well. He is also a sub-investigator for a new neonatal echocardiogram parameter named as PAAT and its potential role in predicting the future risk of BPD. Furthermore, Viera provides his clinical services for newborns diagnosed with congenital heart disease or those requiring ECMO other than preterm infants. We also have with us Professor Tipple. Professor Tipple is the Reba McIntyre Endowed Chair in Neonatology, and he is the Chief of Section of the Neonatal Perinatal Medicine. His research includes studying lung injury related to oxidative stress in animal models. He is an avid mentor and educator. His program actively supports the development of clinician and non-clinician trainees. The other chairperson we have is Professor Giridhar. Professor Giridhar is the professor of neonatology from Chettinad Institute in Chennai in Tamil Nadu. He is also a senior consultant in Neolife Children's Hospital, Chennai. He is one of my mentors. I have been training under him since my undergraduation days. I welcome all three of you. I hand it over to Professor Giridhar to say a few words about the topic that we are about to discuss.
Thank you, Dr. Veeraraghavan, for the kind introduction. Welcome to you all, wherever you have logged in from. Good morning, good evening. So, and it's a pleasure. We are all awaiting listening to people who have done original work in this area. Just a few thoughts about this topic. We all know that the dreaded desaturating baby is a nightmare for the neonatologist. So a blue baby is going to cause problems anytime. So, and we know that a lot of these babies are born late preterm or term or even post-term. They could be born through meconium stain liquor. They could be carrying infections. They could be IUGs. And we know that, we have been managing these babies for quite some time. And I think in the late 90s, early 2000s, there was a lot of variation in management of these children. Especially when it comes to drugs that are being used for these children. But the last decade or so, we have more understanding about the pathophysiology at the molecular level, at the cellular level, about the role of all the signaling molecules, the role of the chemical mediators in modulating the pulmonary vasculature. So, and that came, people recognized that this particular chemical, that is nitric oxide, was a game changer. And since it can be delivered in the inhaled route, people tried this both in animal models and in later in clinical trials in newborns with hypoxemic respiratory failure, and voila, they found dramatic differences, and it was pretty rapid also. And now, as Dr. Veera has been mentioning, this has been a game changer. It's more become like a sine qua non, a gold standard for management of pulmonary hypertension in late preterm and term infants, and even post-term infants. But I think there are a lot of, what we recognize and know at this point of time is, nitric oxide reduces mortality, it reduces the need for ECMO. And so I think when we talk about hypoxemic respiratory failure, we know that a big chunk of babies, that is the preterm infants, are the ones who actually can land up with this sort of a problem. So I think, and we know that India is a country of huge numbers. Numbers are strings, and the global burden of preterm births is the maximal in India. So I think if as a neonatologist managing preterm infants, we would have definitely come across newborns who actually have pulmonary hypertension, be it secondary to the lung condition, or it could be because of some hypoplastic lumps, because of chronic oligohydramnios. So now nitric oxide is not something that is not available in India. I think even though we are a low and middle income country, I think most of the good units, that the level 3 units across India, be it in tier 2 cities or tier 3 cities, have access to nitric oxide, and neonatologists routinely use nitric oxide. But we would like to know about the utilization of nitric oxide in preterm infants, because this is one population where the evidence is quite variable. It is not very convincing utilization, but practice seems to precede evidence, because globally units have used a number of babies who actually have used they have used nitric oxide in equal proportion of preterm infants and term infants. And who better to throw more light in this area than people who have actually used it. So it is very refreshing to see Professor Dr. Tipple here. I think his unit has done a lot of work with nitric oxide in these sort of infants. And I think, welcome, sir. And I'll hand over the floor to you. You can further carry on, and you can subsequently ask Dr. Frederico to start the proceedings, sir. Thank you.
Well, thank you very much for the opportunity to participate. I think a lot of thoughts around this topic, as I trained at a time when many of the large-scale clinical studies for nitric oxide to prevent BPD in preterm infants were underway in the US and around the world. And one of the challenges that exists for researchers like myself working in preclinical settings, that we see very promising therapies that get us very excited about how we might help babies, and then they fail to translate to the bedside. And inhaled nitric oxide in this context would be one of those therapies that, despite very convincing preclinical evidence, the clinical data just do not routinely support routine use. And does that have to do with differences in circulation or cardiovascular hemodynamics? I think Dr. Vieira and other members of our team here in Oklahoma are going to help contribute to maybe understanding what it is that happens when these infants receive inhaled nitric oxide, those infants that are not term, for example. And so might functional echocardiography help us understand the changes in hemodynamics that underlie the pathophysiology that head bleeds, et cetera, that might be a part of this. At the same time, as a biochemist, the chemical reactions between nitric oxide and oxygen, you create something called peroxynitrite, which is extremely damaging to tissues and cells. And so that chemical equation is actually ONOO. So, oh no, and I think it's a very appropriate descriptor, both biochemically as well as what might be happening pathophysiologically in our patients. But there maybe is both reassurance, but also a bit of concern from my perspective, in that this is now the third institution in which I practice medicine. First at Nationwide Children's in Columbus, Ohio, at University of Alabama, Birmingham, with Drs. Ambalavannan and Dr. Carlo. And we had very, very similar experiences. We reach for the nitric oxide when nothing else seems to work, because we want to be able to save our patient. And why is it that we as clinicians continue to reach for therapies and utilize therapies that are not supported by data? And maybe we can understand which select patients, for example, through the addition of functional echocardiography or other parameters that might help us understand who could benefit, rather than trying to treat all patients. And maybe this is a therapy that has efficacy in the right population. And so I look forward to hearing Dr. Vieira's talk as well. He's a very valuable member of our section as an assistant professor of pediatrics, and has great expertise in this area. And so Dr. Vieira, I'll turn it over to you for your presentation.
Thank you so much for the introduction and for the experts panel, panelists here present that will help us answer questions as well. So I'd like to start the talk so we don't get too late. So I'm gonna be focused only on preterm infants. I'm not gonna be focusing late preterm and term. That's well answered. So let's get to it. So I don't have any relevant disclosures. My learning objectives, so I'm quickly touch base on mechanisms of action of inhaled nitric oxide. What are the current recommendations? And despite the current recommendations, is there any evidence that preterm newborn may benefit from inhaled nitric oxide? So I'd like to start with this slide. So if you go back to the first slides about nitric oxide, you see that there's an electron ready to bind to other organisms or other molecules. So we need to know that nitric oxide is a free radical, like oxygen. And when we provide oxygen for our preterm newborn babies, we always talked about toxicity, retinopathy of prematurity, and other complications that oxygen can cause. Nitric oxide is not different. So nitric oxide is there in our environment to bound to something. And as Dr. Tipo mentioned, there's peroxide nitrites that are not benign molecules to our organism. So in the industry, even from 1970s or 60s, nitric oxide is known as a toxin. So if you go to any major industry that have a closed environment, they tend to measure nitric oxide in the environment because they can cause damage. And as you can see here, it is all over the place, from agriculture, transportation. Nitric oxide is present. So you do have to pay attention to that part of the nitric oxide. It is a toxin in general. How our body uses nitric oxide is a little different. So we have our own system that produces nitric oxide. There's 3 enzymes, primary enzymes identified for that, and that's nitric oxide synthase. That one's in your endothelial, that you're going to have function of vasodilation, vasoprotection. But our macrophage also produces, and that's they use nitric oxide. Actually, they can kill organisms, that invading organisms, because nitric oxide is going to bind and destroy proteins, DNA. So you have to keep that in mind as well. But it does have some vasodilation effects as well, even the ones that are produced by macrophage or in our neural tissue. So nitric oxide is produced when arginine, one of the amino acids, suffers hydroxylation and oxygenation process, and ultimately produces the nitric oxide, which is a substance that tends to be lipophilic, so can cross over any barrier that you may have protecting us. Your cell membrane, mitochondria can go all over the place. It's easily metabolized, so it doesn't last long, but is easily produced as well. So in general, in our body, we're going to have a stimuli, our endothelial cell, through the nitric oxide synthase. We're going to produce the nitric oxide through arginine and some cofactors. Then nitric oxide from the endothelial cell, then it's going to go to the muscle, smooth muscle cell. And through a series of cascade, ultimately, what's going to do is going to decrease your intracellular calcium. And that decreasing intracellular calcium is going to inhibit the myosin light chain kinase to phosphorylate our myosin, and that's going to relax our smooth muscle cell. So it's through this process, through a several enzyme process, it's the decreased intracellular calcium ultimately that cause that relaxation of smooth muscle cell. It's worth mentioning that when you provide inhaled nitric oxide, our airway also has muscle cells, not only the vascular portion of our lungs, is also our airway. So there is studies that show that improving lung function after you start INOs, not just oxygenation, the ventilation portion as well. So that comes with some of the benefits we see acutely in our babies that when you provide nitric oxide, especially in the late preterm newborns. Our lung does have a self-protecting mechanism that inhaled nitric oxide is trying to bypass. So there is a hypoxic vasoconstriction effect, and through the rho kinase system, that you can use bosentan for that. There is some questions about bosentan neurodevelopment outcomes, but it's one of the drugs you in theory could use as well. So in areas of our lung that have poor oxygenation, you can consider that in the coronary aspiration syndrome and pneumonia. So what happens, our arteries is not going to be providing enough blood flow to those areas, because if there's not enough oxygen flowing through those airway, why are you gonna send blood there if there is no gas exchange? So what the body does is vasoconstrict the lung, the arteries in those areas, and shunt the blood to areas that are better ventilated or oxygenated. So there's less BQ mismatch on those sick lungs. But if you consider our preterm babies and newborn babies, they have the PDA and PFO, that blood can be shunted out of the lung before going there. That can cause major problems. So it's better to vasodilate everything you can and maximize blood flow to our lungs, so lungs can get gas exchange happening. So that's one of the endogenous mechanisms that INO is trying to fight against. So INO, as I mentioned, there is some toxicity related. One of them that's not necessarily related to the oxidation portion of the nitric oxide, but is more like binding to other substances, is the hemoglobin. So we know nowadays, if you keep a good amount of in the safe range of INO, which is 20 parts per million, that's very unlikely to happen. Usually that happens when people are trying to reach 30 and 40 parts per million. Our organisms through enzyme process is able to clean that, and the methemoglobin is not going to happen. And the problem with methemoglobin, once they happen, oxygen cannot bind to the heme substance anymore, and that's caused hypoxia in distal tissues. Some preterm babies may have a enzyme deficiency, or they may have genetic issues, but it's a very low population. So that's, if you keep it at the 20 parts per million range safety, you're not going to see that very often. But then comes the other part of the nitric oxide. As I mentioned, even our macrophage produces purposefully to protect us. And if you provide inhaled nitric oxide when it's not needed, all this inflammatory process can be dysregulated. Okay, so from this paper here, actually they consider inhaled nitric oxide, if you do not use in the proper setting, actually cause immune dysregulation instead of immune regulation. Can change our COX and all other enzyme process. I'm not going to go through them, but you can imagine that what can happen if you provide inhaled nitric oxide for a long time when you don't need it. And that's maybe one of the discussions why nitric oxide did not prevent BPD, maybe the inflammation portion related to that in the long term. But also I know, as mentioned by Dr. Tipo, has this substance here, can bind to oxygen and create this substance, the peroxynitrite. And he mentioned the ONO byproduct of that. And that can cause DNA breakage, inhibition of mitochondrial respiration, and all sorts of enzyme dysfunction, membrane damage. So imagine in a preterm newborn that the lungs is still under development, and you have a lot of peroxynitrite. Is that lung going to develop properly? No, I think we know the answer by now. That's no, from all the studies that have been done in the past. And that may be one of the functions and one of the reasons why BPD is not prevented by using nitric oxide, despite animal and preclinical trials. It's not really, so you always have to consider now with the development of functional echocardiograms for newborns, which is a developing field right now. And most of units in the US, they're starting to have their own neonatologists that do their own echoes. And the reason they do that is not necessary to diagnose congenital heart disease, pulmonary atresia or coarctation. Their goal is more to look at detailed function of the cardiovascular system. So one of the side effects, I wouldn't say toxicity, but the side effects of nitric oxide is if you're using the wrong context, that can cause more damage than help. So for the patients that have elevated pulmonary vascular resistance, there is no question about INO will be helpful because it's going to decrease your pulmonary vascular resistance. There is better shunt flow through the lungs, and you're going to have a better oxygenation and clinical improvement. But for the patients that may have left ventricular dysfunction, they can be cyanotic, not because of PVR, but because of the left ventricle being dysfunctional. So in those patients, you tend to have left to right shunt in the PFO. So the oxygenated blood, instead of going from the left atrium to left ventricle and then to the body, it goes back to the right atrium because the left ventricle is not pumping blood forward but backwards. So, that oxygenated blood goes back to the pulmonary circulation, and all the extra blood in the right atrium flows to the right ventricle, and now I have a lung full of blood because that keeps shunting. It becomes easier for the left ventricle to pump blood to the PADA instead of the pulmonary and to the branch pulmonary arteries. So that means that deoxygenated blood from the systemic circulation goes back to the systemic circulation instead of going to pulmonary circulation. So that can cause hypoxia itself. And once you add INO, what happens is that PVR drops even more. So all that blood that's not flowing through the left atrium to the left ventricle to the body is going to accumulate even more in your lung system, causing pulmonary edema and even worse in your cardiac output and gas exchange. So that can cause worsening clinical status for those patients that have left ventricular dysfunction. So nowadays, it is kind of recommended if you think about starting INO to any patient to get first an echocardiogram. Our preterm newborns, surprisingly, they tend to have more ventricular dysfunction than we appreciate right now. And that's new research coming through from echocardiogram function done by this new process or mentality that you have to look at function, not only anatomy of the heart. And what is the histology of the preterm lung? So that was a board question for me when I did my neonatal board question. Which baby has a higher PVR? Is it 26 weeks or the 32 weeks? And they present a patient 26 that's severe hypoxia that did not respond to oxygen versus a 32 weeks that did respond to oxygen. So you have to look at the histology of the lung itself. So usually our patients in this phase of the lung development, cannulicular phase and saccular phase. So the younger the patient in terms of gestational age, the lowest development they're going to have between epithelium of the airway and endothelium of the vascular system. So the more preterm, they're going to have an imbalance of the pneumocytes, and the artery capillaries in relation to the airway is going to be more distant, so the interstitial and their relationship is not going to be as healthy. So those patients not going to have a response to oxygen because the gas exchange is poor, but at the same way, they're not going to have a proper nitric oxide function as well, because those substances are not reaching our arteries or capillaries. It's similar to what you're going to see patients that have capillary dysplasia. So the relationship between arteries and airway is not present, so they don't respond well, and that's similar to our preterm babies. The younger they are, less gas exchange is going to happen. It's not because the PVR is high; it's because the airway is not developed for it. So you can give oxygen, you can give INO, and their PVR is not going to drop because they don't have significant resistance, because they don't have a lot of arteries compared to this airway that's better developed. So I know those patients not going to respond. I know it's not because they have poor response itself. It's just because they don't have enough smooth muscle and arteries to respond to. So came all those preterm clinical trials. So I'm going to go through some of the papers that researchers use to explain or justify the attempt to use INO to prevent BPD. Once we knew that INO helped term and near-term newborns, came, of course, the idea, well, would that help preterm newborns as well? So they had to justify that through preclinical trials, and we're going to go through some of them. And I don't think that the data is that awesome, even the preterm clinical trials, but it could explain why you use that for BPD prevention, at least an attempt. So some of the papers use models, and this model specifically here in piglets with cardiopulmonary bypass. So it's like similar to what an ECMO would be. And young piglets, they saw when they gave INO, they have this study less interleukin 8, which is a chemotrectin. So in theory, to control inflammation, especially associated with pro-inflammatory substances, LPS, from gram-negative bacteria. And the other study here, so that's when the data start getting a little confusing. On those patients that had cardiopulmonary bypass and INO, the lung tissue apoptosis was not less, though they had a aggravating factor, which is the cardiopulmonary bypass. But when they're using sham piglets, compare the ones that just did not receive INO and the ones that receive INO, there was a protecting factor there in the apoptosis. So that's one of the debate, like, oh, you're not putting our preterm babies on cardiopulmonary bypass, so that it could justify using INO in terms of lung apoptosis. Of course, there's always a question about the side effects. So imagine if you vasodilate or pulmonary vascular resistance, so maybe there's more tissue extravasation, pulmonary edema. Some of the studies here did not show that, so that INO in theory was safe in terms of lung leak index. It's worth mentioning that all those studies here, they were very short, so no more than 24 hours. Those piglets were exposed to such to INO and cardiopulmonary bypass. So it's hard to extrapolate to BPD newborns because our preterms, they don't develop BPD immediately. It's a long process that takes weeks before they reach and we can diagnose the bronchopulmonary dysplasia. Some other studies, this one using preterm rats, they gave a substance, it wasn't inhaled nitric oxide, it was a substance that is a donor of nitric oxide. And they showed that when those rats were exposed to hyperoxia, the ones that receive the substance that donates nitric oxide, they have a better elastin concentration in their lung tissue, means they were better support. So the interstitium of the lung were better developed, and that would ultimately support better airway for growth, and in theory less bronchopulmonary dysplasia on those rats. Again, very short study. Those rats were exposed for 4 hours, couple hours per day for 3 days. And it's hard to necessarily explain that, extrapolate that to BPD, maybe more acutely, would help our patients, but not that long. Another model for preterm rats, when those rats were exposed to hyperoxia and INO, they have a very similar lung development compared to rats at room air, term rats at room air. And again, those are hours, and it's not necessarily going to extrapolate to bronchopulmonary dysplasia. Another model, preterm baboons, they were mechanically ventilated for 2 weeks, and they were provided nitric oxide for the same amount of time. One thing that's very curious on those in this study, that initially, if you look all those graphs in terms of days, they have very good response in the initial days, but later on, those response they were looking for, QPQS, mean arterial pressure, pulmonary pressures, they were lost. So the arguments of the authors is that, oh, after a week of mechanical ventilation, the development between the two are similar. That's maybe why you do not see the long-term protection of the lung. But that tells us that maybe for BPD, maybe this protection is not there, but it could be there for hypoxic newborns that initially need extra support. But in the long term, that difference was not seen in all those graphs here. Curiously, ventilation-wise, you could see a better improvement in the ventilation function of the lung by nitric oxide. So that's, again, go back to our airway also has muscle, smooth muscle, and nitric oxide could vasodilate and have a better compliance and less expiratory resistance. But the oxygen index was not better. There's no statistical significance here. And that's curious in this study. And the ultimate study that did show a benefit, no questions about it, was this the study New Zealand with preterm lamps. They mechanically ventilated for 3 weeks. And this study, those lamps were correlated to 24 weeks humans. In all the parameters they're looking for, they saw significant benefits if we gave those preterm lamps nitric oxide in terms of resistance, pulmonary vascular resistance, and the respiratory tract resistance. But also showing that long-term development were better if you're giving INO compared to the ones that did not receive INO. So that's one of the studies that point out all the clinical trials that try to use INO for BPD prevention. But then what did Cochrane review tell us? And that's the big question, right? So when we gather all this data, there's studies that were positive, there was some that were not so positive. When you get all them together in our clinical babies, I'm not going to go through every single study because it's not feasible for the time, but we can at least look at the Cochrane review. So if you look at death before discharge in terms of outcomes on the preterm newborn that receive INO, there is no statistical significance. There is no favor in using INO or not using. Maybe there's a little trend, but the N, the power is good enough to answer that question. Did not help the death in our general population of preterm newborns. Similarly, if you look for BPD prevention, bronchopulmonary dysplasia, there is no favor of using INO or not. I didn't put a slide here, but similarly for IVH, retinopathy of prematurity, all the others, complications that our preterm newborns have it, INO was not, did not favor or disfavor use. So it means the likelihood that INO is causing major problems in terms of aging, things like that, is not showing, but at the same time is not showing any benefit. From those Cochrane reviews, we have all this consensus. The NIH consensus recently by 2014 says that there is neither rescue or routine INO improves survival in preterm newborns. The evidence does not support treating preterm infants who have respiratory failure or preventing BPD. But again, I like to point out that cerebral palsy, neurodevelopment impairment, cognitive impairment were not higher in babies that were exposed to INO. So safety is still there, but the benefits are not seen. But I like to point this statement here from those studies. However, preterm infants with clear evidence of pulmonary hypertension has not been separately identified on all those studies. So we have to compare to our term and near term. It's shown if they have higher pulmonary hypertension, those babies do benefit from INO. We look for hypoxic failure, but we didn't look at PVR or pulmonary hypertension per se in those studies. And not always, as I show in terms of development, hypoxia means higher PVR in preterm newborns. It could be related to being extremely premature, but not necessarily PVR, as I pointed out on those slides of 26 versus 32 weeks newborns in terms of PVR resistance. Over the years, as pointed out by our panelists, over the years, INO is still using INO more and more. There's multiple data out there that shows that. And the reason, if you look through this chart, the reason you're using is because you're desperate. I have a baby dying from hypoxia. What else can I do it? And we will try. And I don't think it's wrong to try. You need to have a clear cut to when to stop it or when to provide, and have a clear discussion with family. What are the benefits or not the benefits? But you are using more and more despite of the evidence, even the NIH consensus. Here is our own data, Vermont Oxford Network. We are part of it. It's not published. That data is not published, but it's there in the website to go into it. And you see that over the years, the ones that out of all the preterm newborns, the most premature, the ones that use the most INO compared to the later one. Maybe because they're very hypoxic, and again, you're trying everything you can, but that does not relate to the consensus from the NIH consensus or even the Cochrane results. Again, that consensus from the Cochrane says we didn't look at pulmonary hypertension, right? You didn't separate those babies. Maybe because the diagnosis of pulmonary hypertension is not as easy as we expect for those preterm babies that have a PDA and PFO in that age. Clinically, we can still correlate 10 to 15 points difference between pre and post saturation. That's one of the data that clinically a lot of the studies to use, and it is supported by the cardio-hemodynamic group. Some other findings in the echocardiogram, if you have a right to left PDA shunt, there's more than 6% right to left. That's an indication of pulmonary hypertension on echocardiogram. Other indirect measures, so tricuspid regurgitation. So the blood is coming back from the PDA and flooding our right ventricle. So our right ventricle is fighting the PVR, and the blood's being shunted to the PDA. So that right ventricle ultimately is going to get really dilated because it's not able to properly pump blood to the pulmonary artery. So it gets dilated. So that's one of the indirect factors. The dilated right ventricle is going to have a leftward interventricular set positioning. Okay, that will be another indirect factor. Right ventricular dysfunction. If you remember Starling system, if your ventricles get too dilated, that actin-myosin correlation doesn't happen, so they don't pump properly, they don't have proper cardiac output. And because this septal positioning is pushing towards the left ventricle, maybe the left ventricle could have some diastolic dysfunction, so there is no enough relaxation of the left ventricle for blood to go through the left ventricle. That will be another indication that our severe pulmonary hypertension is not because the ventricle cannot pump, they don't have the proper ejection function, it's just because they don't have the diastolic relaxation properly. And one of the new findings, as Dr. Tipo mentioned earlier, is the pulmonary artery acceleration time. And I'll try to explain here. So this is graph demonstration of how does the blood flow through the pulmonary artery. So that's a normal, A is normal. So we have a very smooth in and out to the systolic cycle of the right ventricle. So blood goes smoothly, accelerate initially, and then de-acceleration as the volume in the right ventricle decrease. If it is a very abrupt initial ejection time, that is an indication that our right ventricle is under a lot of pressure, and the downward flow in the end of the systole is not as smooth as compared here. So there's some kick from the right ventricle trying to push this extra blood outside. And if you have this W pattern, is because our right ventricle, even in the end of systole, is trying to push blood flow through as you know, there's some degree of tricuspid regurgitation. That's what would be a severe right ventricle or pulmonary hypertension sign would be. And that has shown in cardiac cath, which is the ultimate goal. What ultimately diagnose of pulmonary hypertension is through cardiac cath, and all sorts of ages, and that does correlate with that. So we have very good parameters per weight, and that can be easily done by certain views of our echocardiogram to help us dictate this baby's pulmonary hypertension. And one of the things is that now we have starting having some data that even this PAT, pulmonary acceleration time, can have a good predicting value for predicting bronchopulmonary dysplasia in our patients. So more information to come in the near future, but that's very exciting. So what I'm going to present to justify why you should try INO in preterm babies is not from great randomized studies, as was discussed by the Cochrane review, right? You don't have that data. We have a retrospective data, but what is the value of retrospective data? It can be used in certain circumstances. So it's retrospective data, cohort or case controls. They're good for investigating rare exposures or rare outcomes. Doesn't mean that pulmonary hypertension is rare in preterm newborns. At this time, maybe we don't look for on echocardiogram that necessarily, or we don't do pre and post sets as often in our preterm newborns. Maybe we are not diagnosing that as often. It still could be a rare event, but maybe we should look into more close in our patients that are in hypoxic failure. So that's all the studies I'll be using, so no randomized studies. And the initial thought why some preterm newborns can have some good response came from case control studies. So they look the babies that had some good response to INO, and what are the clinical factors or clinical characteristics of those babies. So if they have a diagnosed pulmonary hypertension, it's very supportive that you should use INO. If they have oligohydramnios and preproms and other factors, so preprom in a certain degree that didn't help the lung developing as close, but it wasn't that overwhelming. So some of the studies show that if you have preprom for more than 3-4 weeks, not even INO is going to help those patients. But some level of lung hypoplasia may be beneficial, but not too much. So here are the studies. You can look at the table later. So what I'm going to just finish the presentation, the summary of those studies. Again, they are not homogeneous studies. They have different clinical indications and how they use the INO, what are the characteristics of the patients. But I think there's a lot of still common endpoints on those studies that are worth mentioning. And I'll finish my presentation with that. So first of all the studies that show some response to INO, those babies that are used INO didn't have a lot of IVH or BPD or methemoglobin than the other babies. Some of the studies show that the patients that didn't respond, they tend to have more higher IVH. And that may be because those patients were sick from the beginning and they're less likely to respond to INO, or they're more premature, and so they're less likely to respond to INO. But that's one thing, that the patients that did respond, or the studies that compare patients that received and didn't receive, they didn't show necessarily increasing IVH or BPD. So which are the patients that did respond to INO, the preterm ones? So they tend to have higher weight gain at birth. So most of them point more than 1,000 grams, or more than, at least 2 studies show benefits if they more than 750 grams. So those extremely low birth weights, 500 grams, they're very less likely to respond to INO. In terms of gestational age, those weights will correlate to 27 weeks patients, but most of the studies focus on the weight at birth. How they use ANO, since we know from our term and late preterm newborns that 20 parts per million is the gold standard the way you start ANO, so that's what most studies did. So they started 20 parts per million. The ones that didn't start at a lower dose of ANO at 5 parts per million because they were afraid of methemoglobin, they end up increasing to 20, and that seems the optimal range dose to start it. So when they get to 20, that's when they had the best response. So how they did dictate that, oh, this baby did really respond. So not all of them had echocardiogram criteria necessarily. Some of them did use the echocardiogram to show that the baby had pulmonary hypertension, but they did not follow up necessarily with echocardiogram to show that PAT was better or PVR was lower. So most of them use clinical results. So the oxygen requirement decreased by 15% or had a PaO2 improved by 20 points in OI was not necessarily a good indicator because, you know, you have to correlate OI to mean array pressures, and that's not was a good standard for them. But those two other parameters in blood gases and cardiac oxygen was demonstrated. When those patients respond the best? So the most benefit was seen in patients that start early in life, up to 3 days. Those patients that were in hypoxic failure after 3 days of life, likely they were for another reason other than PVR, not being the pulmonary hypertension necessarily. So those are the patients that they don't have sepsis, or they're starting developing pulmonary interstitial emphysema or some other pathological process that were not related necessarily to PVR. So usually those late hypoxia patients after 3 days of life, they are less likely to respond. And all those patients did follow the same latency as the term newborns, that's 30 minutes to 6 hours. That meaning, if you don't see any response by 6 hours, that you're not gonna see later than that. So it's better just to wean off or stop nitric oxide, because then you're adding a second free radical to your system, because those patients are already a lot of oxygen, then you add on nitric oxide. So if in 6 hours you don't see improvement, there is very, very less likely you're going to see improvement after that. And the ones that did respond well, they were able to wean off completely by 7 days. So they didn't stay long. It's not that they responded, they kept for weeks and weeks. No, they stopped by 7 days. They were able to wean off by 7 days. What are the predictors? So which patients, clinical factors of those patients that did respond to ANO? What are the effects? So first of all, if you have echocardiogram finds of pulmonary hypertension, again, ANO should be used for higher PVR, not for only simple hypoxic failure, because again, the hypoxic failure could be for anatomical reasons other than high pulmonary vascular resistance. Preterm of some degree oligohydramnios, yes, they did respond better. Again, but I'd like to point out that the ones that are extreme preterm for more, I believe more than 14 days, those are very bad predictors because we don't have enough at all. So they're not going to respond. The ones that had early surfactant, so you need a lung that can provide the most ventilation process, so early surfactant, prenatal steroids. And one very curious finding is that all the studies that wait too long to start INO maybe have been too late. So you don't need to wait to be 100% oxygen. The optimal point is more like 16, 70% actually in those studies. So before you get to a point that there is no return, it's better to consider INO if you provide surfactant and steroids. And which ones are the poor predictors? So the ones that had zero response to surfactant. So those babies are so underdeveloped that surfactant has no effect. So very likely INO is not going to do any difference at all. And the ones that are other reasons for hypoxia, sepsis, PIE, so those are the less likely to respond to INO as well. So, my patient did respond to INO. I was able to in oxygen. What does that mean? It did means they're the ones that were responded they had better survival. So I did not put the p-values here, but all those had positive p-values, less than 0.05, and the survival rate was pretty good. So if you have a responder, they may have higher survival. Again, that's our retrospective studies. Causation and correlation is not there necessarily. No, there is a correlation, but not causation. But again, maybe worth trying. They tend to have less IVH and PVL as well, so maybe better control of blood flow. That may be helpful for those patients as well. The two studies that follow long term, they showed less disability. But once again, there is no change in BPD. Even the one that respond to INO, they did not have better BPD rates. Again, nitric oxide can cause damage as well if you don't use it properly. So it's not going to prevent bronchial dysplasia if you lose for a long time. But they did have less IVH and they tend to have less PVL death. So in summary, just as a last slide, I like to point out that INO is a free radical. You have to keep that in mind when you're going to use it. If you don't see response, stop it. Maybe causing more damage than good. INO does not prevent BPD. I think from the Cochrane reviews and those studies, that's pretty clear. And which are the preterm newborns that you should try INO at least? So the ones that are not severe failure, that has some degree of preterm or oligohydramnios, the ones that are worse steroid benefit and receive surfactant, the ones that are more than 750 grams, less than 3 days of life, they tend to have a better response. And ideally, if you have available, do an echocardiogram, consider hemodynamic concepts if you have such availability, dictating that the patient has pulmonary hypertension is a better bet that your baby is going to respond to INO. And that's it. I'm open to questions and comments from panelists or attendees.
Thank you, Dr. Frederico. I'm Giridhar here. I think it was a wonderful talk. It was wonderful listening to you. So we have some questions in the chat box. Before we take up the questions, I have a question of my own. Okay. So in your subpopulation of preterms, which could potentially benefit from nitric oxide, I mean, you didn't mention any gestational age. You were mentioning more than 750 grams. That seems to say that you have not, I mean, the IUGR babies probably would not work. But the data seems to say that the utilization of nitric oxide is more in babies who are born at the limits of viability, 23 weeks, 24 weeks, and 25 weeks. And these babies are likely to be less than 750 grams. So how do we balance this? I think when we have a background of PPROM, pulmonary hypertension, hypoxemic respiratory failure, high oxygen requirement, high ventilation requirements. So we don't want to have an adverse effect because we know that nitric oxide could be potentially toxic also. So how do we balance this? So when do we actually give it or choose to give it in babies who are at the limits of viability?
That happens to us as well. So one of the things is, since it's a non-recommended medication, as I know is an intervention for those preterm population. Some of us, the approach it is to discuss the family. We may try this medication that may cause more harm than good. But one thing to keep in mind in all those studies, if you don't see a quick response, to consider stopping. Don't delay. Don't hope that after 6 hours that's going to continue. I necessarily do not offer INO to those 23, 24 weeks, unless I have discussion with my clinical team, they work, and the parents. So I'm not gonna blame anybody from trying, but I think you need to know your limits and stop if you don't see any benefits. I think that's one of the very important points. And I wouldn't delay surfactant or for hooking up nitric oxide. I think the surfactant comes first. I've seen some of the questions in terms of, oh, just have I know a bad side and start that earlier. No, so do the basic stuff, no, give your surfactant before offering nitric oxide. But again, I wouldn't blame anybody from trying, but I think you need to know when to stop it. I think that's one of the big features. And in terms of the gestational age, unfortunately, the studies itself don't look necessarily in the gestational age. They look in the weight. So that's why I didn't try to focus on that, because I don't have the data from those retrospective studies.
And I would add maybe that, thinking again just about physiology, anatomy, and whatever condition you might be treating at the limit of viability, it's still about ventilation perfusion matching. And so those first steps in optimizing VQ match to give INO the opportunity to perhaps work if there is some sort of response, that baby is capable of response. But it could also be that the limit of viability, when you're dealing with a canalicular to saccular stage lung, mentally, I think that's an important picture for anyone who's a trainee, especially to think about. We're not dealing with a fully developed, fully alveolarized lung. So the diffusion distance between that airspace and the vasculature, and recognizing that the vasculature is very underdeveloped as well, and the mechanism of action of inhaled nitric oxide to relax pulmonary vascular smooth muscle, that might not even be very well developed either. And so thinking about what is the intended physiologic response, and the lack of response could be due to incorrect assumptions about ultimately the anatomy and physiology of that particular patient population. And I think just one other piece, as I see a comment about pneumonia and chorioamnionitis, is remembering that what is the impact on macrophages, for example, on inflammatory cells, and what happens in the context of adding nitric oxide in an inflammatory state, and what does that do to systemic perfusion, and again, thinking about pathophysiology of these infants. I think a myriad of reasons that might explain the lack of efficacy, and just so much more to understand.
Yes, and I'll go back to if you have a echocardiogram that can answer the question, is that pulmonary hypertension related or just prematurity related? I think if you have that available, you should use it.
Yeah, thanks, Dr. Federico. So that was a question, because usually the endpoints when it comes to, studying nitric oxide use in newborns is need for ECMO. So there was a question from an attendee. It's been asking, can preterm infants be put on ECMO? What is your experience on that? And do you try out, what is your, do you put preterms? Do you try ECMO on preterm infants?
Yeah, ECMO, there's a limitation in terms of weight. The cannulas, I believe at this moment doesn't go less than 1,800 grams, if I'm mistaken, or 2 kilos, one of the two. But the limitation is not a response to ECMO, is how big can the surgeons cannulate those patients. And that's all related to the flow. So how the pumps work, how much blood flow I need to come in and come out of the patient. And unfortunately, those cannulas size will not fit those extreme preterm babies. And once you start reaching the 2 kilogram mark, you start talking more about close to those late preterm newborns instead of preterm newborns per se. So
also comparing, I was going to just the amount of circulating blood volume in that infant, when you talk about 80 to 100 mLs per kilogram, and you're talking about very small infants where perhaps their circulating blood volume would be less than that required to perfuse a circuit, and how you can match those two in a way that could be beneficial beyond cannula. I think, even if we could solve the cannula issue, that circulating blood volume would be a significant challenge to overcome. And perhaps with some of the developments in technology around artificial placenta, et cetera, that are things our biomechanical engineers are trying to work and help solve. And perhaps someday that would be feasible.
Yes.
Thanks, Dr. Triple. So Regarding the oxidation index, which you mentioned here, is it the same for term infants when compared to preterm infants? When do you
Yes.
actually consider using them, and when is that you strongly consider using this?
Well, that's a good point, and I really hope the studies that address that more clearly. The argument for some of those studies that the mean urine pressure were not obtained, since those studies were retrospective, have to be able to go back to the old data and look for the mean urine pressure necessarily. They did have PEEP, but they didn't have mean urine pressure. That's why most of the studies did not necessarily use that as a marker. But prospectively, I think that's something, if you are easily controlling yourself, I think you can use that. But I unfortunately cannot say, oh yeah, OI at 25, go ahead and use nitric oxide. Unfortunately, I don't have the data to clearly point to that, because the studies that we reviewed did not use those numbers. Yeah. But for term newborns, I think that's clear. Even for ECMO indications, a lot of programmers use 40 as a number and 25 for and nitric oxide, some places start at 15. So can use that and adjust to your environment, your policies. But for preterm newborns, I don't have the data to.
So do you, the initiation and the escalation, the de-escalation, and the stoppage and the response rate, is it going to be the endpoints are going to be the same in preterm infants compared to the term infants?
Yeah, they were similar in terms of oxygenation, in terms of fraction inspired oxygenation and PaO2s. They are similar. They're similar by 20 points in terms of PaO2 increase, or FiO2 requirements by 0.15. Those are similar. Those are exact, and that's what the rationale for those retrospective stuff. That's the rationale they use. What works in late preterm and term, and they try to apply that to preterm newborns. That's what they use, and it does correlate to the outcomes later on in terms of survivability and disability. Yes.
And I have a question of my own. Looking at the physiology of pulmonary hypertension, the background which causes pulmonary hypertension in preterm infants, so there is very likely to be a lot of cardiac dysfunction. Do you still believe that nitric oxide is the answer to pulmonary hypertension in these population, or do you feel milrinone has more of a role in this population? Since cardiac dysfunction is part and parcel of pulmonary hypertension, especially when it comes to preterm infants, because of the architectural nature of the neonatal heart and its pumping function, everything.
Yes, no, that's a very important point, and that's exactly why the neonatal hemodynamic or a function echocardiogram came to be, because you're treating something that you're not aware, especially in the cardiovascular system. So as upon one of these slides, you need to look at, is that a hypoxia related to, or no, acidosis related to poor cardiac function? So you have to look at the left ventricle function itself. So if you have just poor cardiac output from being preterm, yeah, you're right. I know it's not the answer at all, and actually can cause more harm than good. And that's why if you have available, you look for the function of the heart with the echocardiogram. In terms of milrinone, there is the possible complication of systemic hypotension, and how do you measure hypotension in a 23, 24, 25 weeks? We don't know yet. Even nowadays, it's still a debatable topic. What is a proper systemic blood pressure? Is that you look at systolic blood pressure, do you get mean arterial blood pressure? So I think we're going to have more data coming in the future from the McNamara group in Iowa. that may help us answer that question better. So that's why, one of the benefits I know is that all local doesn't get to the distal circulation and can cause systemic hypotension per se, but which can mirror non-cause. Is that going to affect our blood flow to our brains, cause more IVH, less IVH, PVF? And that's all questions that still need to be answered.
Yeah.
And I would add to that, I think one of the challenges as well is making assumptions again about the physiology and the mechanism of action of drugs in populations in which they've not been studied, and trying to extrapolate that information. Where is that balance between, cardiopulmonary effect of milrinone and a deleterious effect systematically or systemically? And so we make assumptions based off of adult or even pediatric data that may or may not be true. And maybe to address one of the questions I see in the chat as well, and when you have those infants or that we've talked about before with pulmonary hypoplasia, let's say preterm rupture of membranes, et cetera, part of it is also maybe refocusing or readjusting our goals. So does that child need to have an excellent or outstanding saturation, or can we treat them more like a baby with cardiac disease, where we're willing to tolerate more mediocre saturations, knowing that our ability to fully recruit their lung, be that both the airspace and the vasculature, is very limited because of their underlying pulmonary hypoplasia. And so I've certainly been a part of managing children where we managed them with saturations in the low 80s because of their pulmonary hypoplasia, had very modest goals, and nursed them along for weeks using inhaled nitric oxide for them to be able to survive and grow, because ultimately the arbiter of survival is great nutrition and the ability not only to heal, but to grow and continue that organogenesis that's disrupted with preterm delivery.
Yeah, that was wonderful, Dr. Tipple. So, I'll see whether more questions in the chat box. Before that, since you are part of the trial, which is investigating sildenafil for pulmonary hypertension in preterm infants, we don't want you to give the final results. At least, what do you think sildenafil? Is it useful, or at least can you give us just a gist of what you have seen so far with sildenafil usage in preterm infants?
Yeah, sure. Well, just to clarify, the studies for we're doing sildenafil for BPD prevention. So there's preclinical trials that show some positive correlation, but in terms of decreasing PVR, the problem is sildenafil, you don't want to decrease necessarily your PVR in areas that you're not, you have poor gas exchange. That's one of the big arguments about sildenafil in preterm infants that have PVR. So the answer in terms of decreasing pulmonary vascularization in preterm infants is not there yet. So I wouldn't use sildenafil necessarily in extreme preterm babies, because I want to drop the PVR at this moment. And in terms of BPD, it's hard to say at this moment, because once you have a PDA open, a PFO, those changes in blood flow to areas that should not be shunting blood is still under question. That's why you're doing the NICHD group from Duke that enrolled us as well, trying to answer at this moment. But the primary goal of pulmonary hypertension per se is not answered as well. Yeah, so that's very complicated. So there's a lot of contradicting and a lot of groups that withdrew from the study that you're doing because of those unable to answer questions in terms of PVR per se. And what is the consequence of shunting blood to the lungs when they should not be shunting necessarily to the blood?
So the last set of questions, I think in different scenarios in preterm population, preterm population who's on high frequency ventilation for pulmonary hypertension and lung diseases, what is the experience of using sildenafil? And in the background of ARDS like background, what is an experience? And finally in diaphragmatic hernias. I think these are likely to be very, one or two cases that you would have managed. So I think you could share your experience, either Dr. Frederico or Professor Dr. Tipple.
You mean for preterm or for term?
Preterm. It was all directed towards preterm. So I've been who are currently on high frequency ventilation, or preterm infants with diaphragmatic hernias. I mean, these two populations I'm looking at, and ARDS.
Yeah. So the current data in terms of CDH in term, is true sildenafil doesn't decrease ECMO or survivability, even term. We try to use it, of course. And the studies were not correlating INO use and outcomes yet. So it's hard to say per se, but in terms of preterm, I personally, I don't offer sildenafil for preterm newborns, because again, VQ mismatch, are you affecting something that I'm not aware yet? I've seen some colleagues using, I did not see major improvement. Again, it was the last resource. What else can I do? They try didn't work, we try sildenafil, and maybe it's too late to offer sildenafil for those patients. So I don't have a good experience per se. I've seen some of my colleagues using, so I routinely don't offer that. I don't know, Dr. Tipo, if you have any, since we don't have a major evidence, I don't know how you guys are experienced about it.
So I think
it's highly variable.
Yeah.
In each of the institutions at which I've worked, where again, we are the individuals who want to do everything we can and feel like we've done everything we can when a family is staring us in the face, asking us to save their baby. And so for something that's easily accessible and readily available, I would say more often than not, most individuals attempt, but oftentimes without, as Dr. Vieira, I think, pointed out, without clear criteria of what constitutes success or lack of efficacy, and being willing to turn that off. And so oftentimes what I'll see in various scenarios, such as those described, is maybe a very quick and modest response that does not sustain. And I think that's that piece as well, is whether this is something that will sustain, and having that informed conversation with the family that we have this to offer. What is the challenge that we have, and to some degree, is we have evidence that that really says we shouldn't do this. Whether that's a congenital diaphragmatic hernia, or again, I still remember being a trainee and saying, well, the evidence says not to use this, so I'm not going to start it. And when the team arrived in the morning, they started it. And so for us to be consistent across our practice is a real challenge. And then I think, again, coming back, I know I sound like a broken record, but coming back to what are we treating and what do we think is the underlying mechanism for the patient's current condition? And do we think that there is benefit beyond the risk associated with trying an unproven therapy, or in cases where the data really don't support its use and actually discourage the use? How do we control ourselves to not decide to try things that in our hearts we really know aren't going to work, clinically speaking, but we want to make sure that we did everything that we possibly could. And now that inhaled nitric oxide, or at least the mechanisms for administering inhaled nitric oxide in the United States are out of patent protection, the availability, because nitric oxide is not an expensive agent to use, but it has significant expense associated with its use, at least certainly in the United States, because of the patent rights for the administration devices to deliver to patients. No longer, and I remember my professors telling me the stories of going to the loading dock and getting a tank of nitric oxide and bringing it to the unit and administering it to a patient. Not something we could ever do. And so we're going to have to really be very measured in how we approach its use now that it's going to be more readily available for us as well. So no answers. Sorry for those who are asking, except for we have to do a better job of policing ourselves and how we utilize therapies. And that's the challenge with the field that we've all chosen to dedicate our lives to.
And there's opportunity for research, whoever wants to join the world of research, that a lot of questions should be answered, definitely.
Sure. So that completes the questions in the chat box. So I think, from my side, I'd like to thank Professor Dr. Trent Tippel and Dr. Federico for having delivered that lecture. You have clarified a lot of problems when it comes to utilization of nitric oxide in preterm infants. So I'll hand it over to Dr. Veera to conclude the proceedings.
So I appreciate the invitation from Dr. Ramaswamy, Dr. Seturaman for participating in the talk, and Dr. Tipo. I hope I pronounced everybody's names correctly. I'm so sorry if I did.
Yes, definitely you did so. Yeah.
And I hope to continue in contact with you, your group, and participating even in your talks and learning from you guys as well. So thank you so much for your time.
Thank you.
And similarly, thank you for the opportunity. And if ever in the US, anyone on the call or on the Zoom or the other co-hosts, please reach out and come visit us here. Would be really open to that once the world allows us to travel a bit more freely again. And so be well and our best to everyone's families as we continue to live through such a trying time.
Yeah, absolutely.
Thank you, Dr. Frederico and Professor Tippel and Professor Giridhar for this wonderful session. I got more clarity related to INO use in preterm newborns of less than 34 weeks gestation. There are three aspects that I want to indicate. One related to my experience of using INO in babies who were born at 22 to 24 weeks. I had encountered it for the first time in UK when I was in Oxford, because we don't care for such babies back here in home in India. The things that I felt that we were doing wrong after listening to this talk was initiating it a bit late when we reach 100% O2 and we have no other way to go. And the second thing is not to stop it once we start it if we don't get a response. I have never seen a single baby being stopped whose nitric oxide was stopped when it did not respond there. And the second aspect is related to a primary research that we had done on looking at outcomes of the babies born at 22 to 24 weeks, the results of which were in sync with what Frederico had presented. The responders had a better chance of survival without major brain injury in this subgroup of population, those who responded to INO. They survived with no severe IVH or PVL. And the final thing in which I have quite good clarity on is based on a secondary research project that we are involved with along with Professor Tippel's good friend Gary Weiner, is on an umbrella review which is about to be submitted for peer review on interventions to prevent bronchopulmonary dysplasia, where we found 3 interventions which resulted in a decreased risk of BPD at 36 weeks PMA, but not the combined or competing outcome of BPD or mortality, indirectly indicating that it increased the risk of mortality. These 3 interventions with high certainty of evidence included: 1, inhaled nitric oxide as a preventive measure for BPD, 2, vitamin A supplementation, and 3, lower oxygen targeting lower oxygen saturation. So this is my perspective on INO from whatever personal practical experience that I had in UK with respect to the primary research or the secondary research that we had done. And I thank Frederico for giving a very crystal clear presentation on when to use INO in newborns, when to stop it, what to expect when you have a response, when to expect a response, and who are the ones who can respond. Thank you. Thanks for your talk. Thanks, Professor Tippel, and thank you, Professor Giridhar, for participating in this webinar. And thanks all of the delegates who have joined us.
Thank you so much. Thank you.
Thank you.